It is really only fitting that our first keynote speaker comes from someone who is no stranger to Morehouse School of Medicine. I can't even recount the number of conversations that I have had with Dr. George Russ as I took on the role of Dean and Executive Vice President at Morehouse School of Medicine. I always saw him as my thought partner in helping me to really crystallize what it meant to be first engaged with the community, what it meant to listen to the community, what it meant to have multiple stakeholders at the table when you were trying to craft solutions that would benefit the community. Currently, he serves as a professor at FSU College of Medicine in Tallahassee, where he directs the Center for Medicine and Public Health. He also serves as the medical director for the Leon County Health Department and the 5 surrounding rural counties. He's board certified in both family medicine and preventive medicine. And I can tell you from the work that he did here at Morehouse School of Medicine for 24 years when he served as a faculty, and when he served as the founding director of the Morehouse Faculty Development Program, as well as the National Center for Primary Care. The work that he's doing right now, guys, he's in his element. This is what wakes him up every morning. And the thing that I have always loved about him, he was going to make sure that you were heard and that you listened to the why we are doing this work. In 2015, he was the senior scientific advisor to the U.S. Agency for Healthcare Research and Quality, AHRQ. There, he really did help forge a pathway for the work that that center, or that agency should be focused on. He's always focused on population health outcomes as a health equity researcher. But what I have appreciated about him the most, and if you go back and look at his peer-reviewed publications, you will see that the audiences that he was speaking to were not just those that sit in the white towers of academia. He was speaking to local and state and national leaders who would be empowered to take that information and to implement change. It is indeed my honor to introduce you all to Dr. George Russ. And even though he has moved on from Morehouse School of Medicine, we will always claim him as our own. George.
Thank you so much, Dr. Montgomery Rice. It's been an honor to be able to work with you and to know you in your years at Morehouse and the time I spent there, and just the phenomenal way that you've helped to focus the institution and its mission on health equity, and really to becoming that national leader in the health equity space. So thank you for that, and thanks for letting me be here with you today. I got a couple of messages on social media saying welcome home, and that felt really good. I do think of Morehouse School of Medicine as my home. Let's see if the slides are, oh, isn't that beautiful? I think the thought and it, speak it into being. The slides are up. What we're going to talk about today is that notion of cultivating and achieving health equity, with a special focus on how these 3 concepts of primary care, innovation, and leadership intersect to give us tools to use in achieving health equity. Obviously, I love my time at Morehouse School of Medicine. Almost a quarter of a century that I spent there shaped me, helped me to become who I am, but also to do the work that I did in a way that had integrity and meaning for me. The focus on primary care and underserved communities when I got there morphed into a broader sense of achieving health equity across all populations. And that's exactly what we need in terms of training the professionals America needs and being the voice that America needs in this space. It's there that I got to do work with Dr. David Satcher, mentor, friend, just has inspired me in so many different ways. But doing this work of beginning to ask the questions about what if we were equal, not just documenting disparities, but beginning to frame it as a question of how do we get there? How do we make this not so? The disparities that we see and the inequalities that we see. In the National Center for Primary Care, one of our more significant initiatives in partnership with the Minority Health Advisory Council of Georgia was to publish the Georgia Health Disparities Report and the Georgia Health Equity Initiative, giving a report card on how we were doing on equality versus inequities across every single county in Georgia, 9 different domains that we looked at, summed up in grades. One of our local counties in Atlanta got an F. We didn't plan it that way. That's just how the numbers came out. I got a lot of really interesting phone calls from county commissioners that week. People who I didn't think knew who I was, but they found me. But what we found in Fulton County alone, 28,000, in Fulton and DeKalb counties, the 2 core counties of Atlanta, 45,000 excess years of potential life loss due to premature deaths directly attributable to racial disparities. And the way I would frame that is, how many grandmother years, how many grandfather years, how many wisdom years can one community afford to lose every year before it begins to have a much more dramatic impact on the health of us all? Obviously, it's not just racial disparities. We've got racial disparities across, we've got disparities across all kinds of domains, from race and ethnicity to gender and sexuality, rural, urban, socioeconomic status, people with different diagnoses, mental health diagnoses as a specific source of stigma and disparities. And so many of us have a couple of these in intersectional identities that we need to find ways to address, not just one at a time, but in whole, for whole people. We began to move beyond just documenting disparities and breaking through the denial that, well, that's an old problem, but now we're doing things right. Documenting those disparities and beginning to look at the causes of disparities and what people call the determinants of disparities. And you will see me every single time I say the word determinants, I will do this because I hate that word. It feels deterministic. It feels like there's nothing we can do about it. And I'm going to try and convince you by the end of this talk that that ain't so. The other thing I'd say about this upstream, midstream, downstream model of disparities is we think of it as a river and it flows in one direction. But this is a magical river. And this is a river that flows in both directions. If we address health disparities, if we help people, if we help us not to have 45,000 excess person years of life lost, of wisdom years lost in the African-American community in Atlanta, what do you think that does to socioeconomics of that community? What do you think that does to the community resiliency? What do you think that does to our ability to influence policy upstream? And so this is a magical river that flows in both directions. And it's not deterministic of outcomes. We can intervene at all of these different levels to begin achieving health equity. One of the reasons I don't like this word determinants is it does feel like it's just this overwhelming sense of it's things we can't overcome. It determines a bad outcome. There are disparities and deficits and determinants. And these 3 Ds I'm trying to eliminate from my language because they lead to despair. They lead to a sense of powerlessness. And that's not where we need to be. Dr. Bob Levine, when he was research director of the National Center for Primary Care at Morehouse School of Medicine, led us on a line of research that I think was really powerful, which is that there is evidence that equality is achievable. And part of that evidence is that some communities are already achieving it. He published studies where he demonstrated that there were counties in America where African-American men had exactly the same mortality rate as the US average, even though overall for the nation, African-American men were dying at much higher rates. There is evidence that some counties that just isn't true. Equity is achievable. Equality of outcomes is achievable. And we use the language that racial disparities are not inevitable. Now, I know that we've used for this conference the imagery of an airplane flying on a journey to health equity. I love that because I remember the sessions in our NCPC research team where we draw the airplane on the board and talk about flying together there. But I will say that we can sometimes imagine that we're sitting in the airplane waiting to get to that ultimate idealized reality of health equity. And I've come to love Dr. Camara Jones's tale, A Gardener's Tale, where she talks about cultivating health equity, of creating the circumstances, creating the structures, undoing the bad soil, if you will, of institutional racism, of individual racism, of structures that are tied to a historically white past that has led us to a place of these disparities. And so we can begin to imagine the journey to health equity as one not only where we're getting from here to there, but one where we're planting gardens of health equity all around us wherever we are at this moment. And if each of us are doing that together, even as we're moving toward health equity as an idealized ultimate outcome, it turns out that we've planted gardens of health equity around us. And at some point, enough of us are doing that the health equity gardens merge and we're all together and we wake up one day and we're in a garden of health equity, not arriving at some place distant. You've all seen these slides before. Difference between equality and equity. Giving everybody the same bicycle doesn't work. Giving people bicycles that are made for them to allow everybody to ride is what equity is all about. I have these conversations here in Florida now, and it's a little difficult with our current leadership because they don't like the word equity. So whenever I'm on the State Health Improvement Plan Steering Council, I just repeat the word equity at least 7 times during every meeting to watch our Surgeon General twitch. But what I'm willing to say is, if you don't like the word equity, I'm fine with using the word equality as long as we commit to equality of outcomes. Because if we're committing to equality of outcomes, then you have to address the inequities upstream and you have to treat people differently depending on their needs and their strengths. And you have to do equity even if you don't like the word. What I think a lot of us are moving toward is the word justice, which is that we can imagine a time when we don't need to do special things for different subsets of the population. If we reduce the structural barriers, if we eliminate the structural barriers, we achieve justice and everybody can see the ballgame. Well, I was given the themes of primary care, innovation, and leadership. And it struck me that this was parallel to something I've used before, the framing of this as part of the dialogue in the movie The Help, where actor Viola Davis, who does a wonderful job in that movie, teaches a little girl that you is kind, you is smart, and you is important. And I'm going to steal that for a moment and say that being kind is kind of like primary care. And being smart is kind of like innovation. Being important is exerting leadership. And so we're going to follow that theme through here and see if I can get us to where we need to get to. Dr. Lonnie Fuller, who recruited me to Morehouse School of Medicine, I love him to death. He passed away a few years ago. His son now carries on some of the same work, but he introduced the phrase primary caring in an article that we actually worked on a little bit together called A Piece of My Mind and published in JAMA. But one of the sentences he said in there is, how do we, in the process of teaching the medical sciences, amid all of our technology and all this other stuff that we do, how do we create a renaissance of compassion and caring and humanity? And that was how he tied it to primary care. called it primary caring. Dr. Otilia Mariño was the medical director of the West Orange Farm Worker Health Association before I arrived. And 2 to 3 months later, she decided that she was moving on to another opportunity and was handing the keys to the car to me as medical director, 3 months straight out of residency. And I think she was a little bit nervous about turning over this organization that she had poured her heart and soul into. Wanted to make sure I really got it. And she took me out to lunch and she said, George, when I'm in the room with a patient, in the primary care setting, when I'm in the room with a patient, I feel like a priestess because people share things with me there that they would not share with their spouse, with their parents, with their kids, with their friends. And sometimes I can't fix it. But what I can do is hold their hand and walk with them on their journey. And that's part of the healing of primary care, of primary caring. That's why it's relevant to health equity, because everybody needs access to that. Whether we can actually heal or cure, whether we can prevent a disease, or whether we can be with someone in their suffering and hold their hand and walk with them on their journey. And it turns out they don't live in our patient-centered medical homes. Our patients, our communities they live as free-range humans. They do stuff out there that I don't even want to know about sometimes. And we have to figure out that primary care extends beyond the exam room. When I would do home visits occasionally on the side of Groveland, Florida, that didn't have paved roads, there's a whole different reality there that I needed to take into account when I was giving sometimes what was silly advice, doctor's perspective on how people should live or eat or behave. Changes your whole mindset when you get into the homes of individuals and understand their realities, both their challenges and their strengths. So we treat people in context. That's what primary care is. And that context often includes people who are clinically, medically very complex, but who also have behavioral health complexities, social complexities. And those complex people require complex care. That's why primary care is a team sport. We don't do primary care as individual physicians. It's a team, and increasingly, it's explicitly a care management team. That may include social services, it may include behavioral health specialists, psychologists, social workers. It may include community health workers and peer support, and typically includes community partnerships as well. Maybe group visits and panel-based care management in the new models of primary care. But it has to go above the neck. You can't do primary care just as below the neck medicine. Mental health, behavioral health is a part of our practice. Here at FSU, the faculty that I am most fond of actually practice down in Immokalee, Florida. It's a largely immigrant community, agricultural community. We take our students down there for a 1-week immersion experience in farm worker health. But these faculty live and work and practice in Immokalee, Florida. And those faculty are psychologists, actually, run a postdoctoral psychology fellowship there. When you go to the clinic, the Federally Qualified Health Center that they partner with, the first thing that happens for a child visit is that they will fill out on a kiosk, not where they have to read, but with little earplugs in their own language, Haitian Creole, English, Spanish. They'll fill out an adverse childhood experiences survey, an ACE score. And the kids with ACE scores above a certain level, that day will see not only the pediatrician, but the psychologist. They'll see Dr. Messidor speaking in Haitian Creole, fluent Haitian Creole, helping them with their mental health issues. They'll see Dr. Elena Reyes or Dr. Javier Rosado, and they'll address those issues and work with them in an ongoing kind of way. But you see Dr. Rosado here out in the community in a school leading sessions. He doesn't look at primary care or health care as being bound by the clinic walls. He's in a school dealing with kids, dealing with parents. And they even wrote a children's book, helping children deal with their grief about leaving when they move around a lot and leave friends behind. So we do have to move beyond the clinic walls. Primary care is not an inside the building sport. It's a team sport, but it's a team sport that extends into community with lots of partners if we're going to be successful at achieving better health outcomes for everybody, and particularly to achieve health equity, equitable and optimal health outcomes for all. An example, who's doing this right? The South Central Foundation, Anchorage, Alaska, is one of my favorite organizations, has gone through a transformational process where there used to be a government-owned Indian Health Service clinic site, and ownership was transferred to the community. And a community governing board runs this organization. Indigenous people work and lead the organization. And that's one of the characteristics I think you'll see of organizations that are doing health equity right. Who has the power to set policy, to hire, fire, to make budget decisions? What's the balance between professional culture, corporate culture, and community culture? Here, community culture is the culture of that organization. So I'd ask each of us to think about that for a minute, especially those of us who work in a historically white institution, as I do now. Are you striving for diversity and inclusion only within the limits of the historically white medical professional culture that you already have? Or are you seeking to become something entirely new, driven by community culture in a non-white world? South Central Foundation uses the phrase NUCA, a word in their own language that means strong giant structures and living things. There's real community ownership and governance. They call their patients customer owners. The whole thing is family-centered, relationship-based care. In fact, the first thing they did was switch their medical records from individual medical records to patient-based medical records. They have integrated team-based care, including native healers, along with psychologists, primary care, and nurses. And you may say, that sounds really huggy, touchy-feely. They even have massage therapists on some of their teams. Sounds soft stuff, right? 40% drop in ER visits, 36% drop in hospital stays, 97% customer owner satisfaction, and 95% employee satisfaction. Don Berwick called it the leading example of healthcare redesign in the nation. So primary care is primary caring, but it's way bigger than me sitting in an exam room, one patient at a time. Innovation. We got to be smart. We got to innovate. Albert Einstein said creativity is intelligence having fun. We got to have fun along the way. And America has had successes with innovation. When we looked at America's success stories, which of the leading causes of death in America have had at least a 50% reduction in mortality? What we found was 7 of the 9 conditions that met that criteria had a research, discovery, or innovation at the heart of it. And they then implemented that through both public health promotion and primary care or other healthcare delivery. HIV/AIDS is a classic example. Death rates going up, up, up. This is the most dramatic mortality curve you'll ever see. Death rates going up, up, up nationally. All of a sudden, 1996 to 1998, we get protease inhibitors. We get drugs that are highly effective. A terminal disease becomes a chronic disease and death rates drop. But it didn't drop for everybody at the same pace. Technology doesn't always benefit all of us equally. And sometimes, if you think about the diffusion curve, if you've read The Tipping Point, or a better book is E.M. Rogers' book, Diffusion of Innovation, what you know is that while you can draw these curves, the curves are not the same for every segment of the population. And gaps in the diffusion of new life-saving technology, new innovation, often lead to exacerbation of disparities. When we didn't have ways to prevent heart attacks and strokes and deaths from that, everybody died at the same rate. When those rates started coming down dramatically, the gap actually widened. Innovation can exacerbate disparities if you don't explicitly pay attention to it. It's not the same everywhere, though. And so some of our research has been to show that in some communities, the gap doesn't widen. In some communities, it stays parallel. In some communities, there was never a gap. And in some communities, these are the most interesting communities of all, we actually converge on equality. We start with disparities and we achieve equality. It is possible. Disparities are not inevitable. Here in the COVID epidemic and pandemic, I've been watching how we've applied technology to solve a world problem. And look how fast we began to understand the virus itself. Look how fast we developed the vaccines. In the public health departments in which I work, we have surveillance systems for this. Almost everybody in the community knows how many cases a day, cases per 100,000 we have of COVID in our community at any given point. We know how many people are in the hospital front. We have these just incredible surveillance systems. And with our epidemiology team every Wednesday morning, I'm hearing about all the other things going on in the background in the community. We've had a little meningitis outbreak. We had some Campylobacter cases. Salmonella was it the oysters, or do they have chickens in their backyard? Okay, we got that. But there's this ongoing surveillance system and a rapid cycle feedback loop where we jump on it immediately. Why aren't we doing that with disparities? Where's the real-time surveillance system? Who's sitting at a dashboard in public health saying the asthma disparities among children, the black-white disparities are widening in our community? What are we going to do about that? What's the intervention we can do? How can we do a rapid cycle feedback loop to see if the intervention is working? And then hold ourselves accountable to actually move the needle and fix it, to expect a positive outcome. Harlem Children's Zone has shown us how to do that with their asthma initiative. Decreased emergency department visits from 35% to 8%. Hospitalizations for childhood asthma from 8.6% to 0% by doing community level interventions, primary care interventions, rapid cycle feedback loop, keeping your finger on the pulse and looking at the data every day. We're starting to see more and more of these examples where we're not just documenting disparities, we're not just understanding the reasons why we have disparities, we're not talking about determinants, we're fixing it. We're actually making it better. We're achieving equality of outcome. Cone Memorial Hospital or Cone Health System had a program they called Accountability for Cancer Care Through Undoing Racism and Equity. They, some years ago, showed that there was a gap in people completing treatment for breast and lung cancer. They identified specific barriers. They intervened with a human component, nurse navigators for relational trust. They measured their impact and outcomes in real time. Fairly quickly, they demonstrated that they could eliminate that problem of people completing treatment for breast and lung cancer. But what they proved, and they just presented this about a year ago, they actually improved breast cancer survival rates, both for Black patients and white patients, by paying attention to this stuff. Both groups improved, and they specifically completely eliminated the disparity in rates of survival between the races in breast cancer for the population that they serve. That organization has made a commitment to health equity, and it's not just in doing this project on the community. They've been in an ongoing dialogue with community where the first step was to own up to their own historic racism, to acknowledge it, to apologize for it, and to begin to rebuild trust that they had broken years before. So we got to balance our high tech with high touch. It's relational, not informational, is the mantra that our community folks always hear from me here. All right, let's talk a little bit about leadership. And this is a little bit like young priest saying mass in front of the Pope. So Dr. Satcher, I bow to you in terms of the leadership space here, and I'll just offer a few thoughts on it, but you are my inspiration here in that space. But one of the things that good leaders do is speak positive outcomes into being, believe in them, and keep their eye on that prize. Whether it's Desmond Tutu or Nelson Mandela in South Africa, whether it was Cesar Chavez and Dolores Huerta in the farm worker movement, they saw a possibility of equity. They saw a possibility of justice way before the rest of us thought it was possible. And they spoke it into being, and they worked it into being, and they lived it into being. We have to create an expectation of an equitable outcome, but then we have to hold people accountable for getting there. Dr. Joe Brown Spates and I and some others here at FSU published a study in the American Journal of Public Health showing exactly when every state would achieve equality of Black-white infant mortality rates if they continue on their current trajectories. Right now, Florida is aiming for 2,213. I mean, it's horrible. But there are states that will do it within my lifetime if they continue on the current trajectory. And if we had a rapid cycle feedback loop for this and tried new stuff and kept trying it and failed fast and failed forward until we got it right, we could accelerate this and hold ourselves accountable for achieving better outcomes faster and ultimately equitable outcomes. Now, leadership is not just for people with formal titles of leadership. As Dr. King said, everybody can be great because anybody can serve. Everybody can be a leader in your own space. Be a 360-degree leader. Lead up, lead down, lead sideways. Anybody can serve. And sometimes that means getting out of our comfort zone. I am not a chain myself to the White House fence kind of guy. I'm not out there typically, leading the protests. But sometimes you got to stand with people. And sometimes you have to, that's the only way to bring voice to issues. This top left picture is residents who ultimately became my faculty at Cook County Hospital on strike in front of Cook County Hospital. And some of their demands were things like, we need a curtain around every bed for privacy and dignity. We need a blood pressure cuff on every ward. Residents shouldn't work 36-hour shifts in an emergency room where you never sit down. And Dr. Pat Dowling actually is the third guy in the back there. He doesn't have a white coat on. He's the tall leprechaun looking guy back there. Served as chair of UCLA's Department of Family Medicine. He was my program director in residency program. And he taught me this quote from Rudolf Virchow, who apparently invented the lymph node. The physician is the natural attorney for the poor. Medicine is a social science, and politics nothing more than medicine on a grander scale. Now, sometimes it might be my voice that needs to be in the game. Sometimes I need to be quiet and listen to community voices. Sometimes I can amplify community voices. This is the Coalition of Immokalee Workers, one of the most effective labor organizing groups in the nation in this century. Led the Taco Bell boycott and other things. And my role now is to support them, not to speak for them. I'm going to ask explicitly, is there a role for white guys in leadership to cultivate and achieve health equity? And I'm going to say that because whenever I walk in a boardroom or I walk in a C-suite at a hospital, there's a whole bunch of white guys around. But they're serving non-white communities or very diverse communities. They have all kinds of diversity on their front desk staff. They have all kinds of diversity among their nurses' aides. But the higher we go with the power structure, the more white and the more male it becomes. Is there a role for me in achieving health equity? I'd say yes. First, we have to own the problem. We have disparities. Disparities are real. They're unfair. They kill people. They hurt people. I am, and my institution is part of the problem. I can, and my institution can be part of the solution if we're willing to spend our privilege. And the choices we make now and every day will determine whether we become more or less a cause of the problem or a source of the solution. AAMC, I think, has made tremendous progress in this space in recent years. In the COVID pandemic, people were framing a problem in our community as trust issues in the African American community. And we had to say, no, you're getting it wrong. The issue is not African American trust. The issue is white institutions' trustworthiness. We've blown it for centuries, and we're still blowing it. People in the community didn't distrust researchers because of Tuskegee. They distrusted researchers because last week they were disrespected at the hospital. Because last year somebody in their family died because their symptoms weren't taken seriously in the hospital. So there is that continuing thread. And yes, it includes Tuskegee, and yes, it includes segregated hospitals and segregated doctors' waiting rooms. But we've got to work on our trustworthiness. I love their first, I'm not going to go through all these, but if you hear somebody use the phrase, we've got to educate the community, I invite you to read number 1. The community is already educated. That's why it doesn't trust you. I would encourage everybody to go and look at these, because I think for many institutions, these would change how you approach what you do. So for me, as a white guy in a non-white world, I've got to figure out when is the right time for me to step up? When is the right time for me to lean in? When is the right time for me to stand by and stand with? When is it time for me to step aside and ultimately to step away? With my voice, I need to start first by listening. And then maybe I need to give voice when others don't have that voice. I may need to speak up and speak out, but then I may need to amplify others' voices. And then it may be time for me to be quiet. And usually it's time for me to listen again. Jack Geiger is a white guy who made a huge difference in the health equity space, started the first community health center in the Mississippi Delta, first community health center in the country. But he did it in partnership with John Hatch, who was the head of the community organizing Delta community. He looked at it as an opportunity not to provide primary care, healthcare services, but as an opportunity to partner with community and find strength in community and address health. That means starting with people's assets, not their deficits. A true partnership builds on the community's strengths. In the disability community and then in the mental health community, the phrase was nothing about us without us. I've adopted that for my work in community health. Nothing about us without us. We don't do to or don't do for, we do with. There's a little, the other thing, I can actually hold it up. It's been on my computer monitor for the last 30 years. And it's this: go to the people, live among them, learn from them, love them. Start with what they know, build on what they have. But of the best leaders, when their work is done, the people observe. We have done it ourselves. I've got pictures here of all the people at Morehouse who inspired me in that space. There's dozens more. You got so many of them, I can't fit them all on the slide. But so are we journeying to health equity? I love the title of this book, Call Me When You Reach Nirvana. I'm not sure I'm ever going to get there. We can send photos of our journey. That outcome is critical. We used to show a slide like this for Georgia, but the numbers are similar in Florida. 328 now is the number of babies who die every year in Florida that would not have died if we eliminated the black-white infant mortality gap. That's a baby almost every day who dies in Florida who wouldn't have died. But let's say it in a positive way. We have the opportunity to save a baby's life every day in Florida if we eliminate this disparity in birth outcomes. Can you do it? Is it possible, or is it too overwhelming? Go to the poorest place you can think of in the world. Go to the most under-resourced countries in the world. What you'll find is that from 1970 to 2010, the under 5 child mortality declined almost 50% through interventions like vaccines and child nutrition and oral rehydration and community development work. And we are on target to achieve another 50% reduction in that under 5 child mortality by the year 2035, if y'all get in the game, because I may be too old for this by 2035. So let's just sum it up. You can use this framing, cultivating and achieving health equity. You can use the framing of be kind, be smart, be important. Do primary caring, broadly defined. Innovate, but balance your high tech with high touch, always prioritizing relational trust over information or tasks or tools or technology. Be willing to be important. Know when to step up and speak up, when to stand side by side and amplify another person's voice or the community's voice, when to step back and shut up, because the community's got this. The right mode of leadership in the right place at the right time. make a difference in your world. I'm going to encourage all of you to take on this journey, but not a journey where you sit on a plane and wait till we get there, but a journey of planting seeds and sharing the vision and doing the hard work right where you are right now, but with an eye on the prize of ultimately achieving health equity. Cultivate that health equity wherever you are and wherever you go. And I'm going to ask each of you to think for a moment about this. What is your role today in cultivating and achieving health equity where you are? Thanks for letting me be here with you today.